It shows when you're nervous, things can happen. The avalanche of reports was tremendous. We actually allowed the safety to be authorized with just 2 months of median follow-up rather than the normal 6 to 12.
So why were you pressuring the doctors and then removing them from the approval process when they disagreed?
The approval process was one that was needed to move as rapidly as possible. 1 in 10,000 to 1 in 20,000 individuals got myocarditis, and it's estimated that globally COVID-19 vaccines have saved over 14 million lives.
I'm not a doctor, but I have a PhD in recognizing bullshit when I hear it.
I'm a PhD in BS. It means Bulgarian sunshine.
Our witnesses today are Dr. Daniel Jernigan. Dr. Jernigan is the director of the National Center for Emerging and Zoonotic Infectious Diseases at the U.S. Centers for Disease Control and Prevention. Dr. Peter Marks. Dr. Marks is the director of the Center for Biologics Evaluation and Research at the U.S. Food and Drug Administration. Commander Dr. George Reed Grimes. Commander Grimes is the Director of Injury Compensation Programs at the U.S. Health Resources and Services Administration. I want to ask each of you this question, or at least Dr. Jernigan and Dr. Marks, yes or no. Is any pharmaceutical 100% safe?
Thanks very much for that question, Chair Wenstrup. No pharmaceutical is 100% safe. In fact, even the water we drink is not 100% safe. If you drink too much of it on a hot day, you can die from complications of water poisoning.
Well said.
Yes, thanks for the question. You know, as clinicians, we all recognize that no medical intervention is risk-free.
And I'll go to Dr. Grimes. You know, there's a reason we have a compensation program.
Yes, sir. So there's a reason we have a compensation program, and we're dedicated to diligently carrying that out. I can't say it any better than my colleagues sitting next to me have.
Thank you. As of February 2024, VAERS reports for COVID-19 vaccines total significantly higher than all other vaccines combined since 1990, as reported. This is a surprising figure. Dr. Marks, was the government prepared for such an avalanche of reports to VAERS? And it kind of goes with what we just mentioned. So,
Chair Wenstrup, thank you so much for that question. And I apologize about your name before. It shows when you're nervous, things can happen. But the point is extremely well taken. We tried to be prepared for that. But the avalanche of reports was tremendous, and it, again, required retasking people on the fly I think and I'll let my CDC colleagues speak to this, we had to hugely staff up and had many meetings working to increase our ability to go through these reports because, as you already mentioned, what the public sees on the public VAERS page is just a small fraction of the information that we ultimately collect and sift through that is very important to determining whether an adverse event is truly related to the vaccine. Now, one of the criticisms that we often receive is that we don't make that additional information available. And I would say to you that it's a challenge because what we've learned is it's very challenging to make available essentially protected health information because if you have a zip code that someone was pregnant, if you have a zip code of someone in Akron, Ohio, that they were pregnant and they had COVID, you can potentially re-identify them. So this is one of the challenges we face in making available information, but I think we'd like to work to make the most information available as possible.
Dr. Marks, your division of the FDA is responsible for evaluating clinical trial data to authorize and approve products, including the COVID-19 vaccine. Could you please explain for us the rigorous standards the FDA has followed in its authorization and approval processes for the COVID-19 vaccines?
Thanks so much for that question, Ranking Member Ruiz. The COVID-19 vaccines, before we even started to receive data, we put forth guidance first in April and then subsequently in October of 2020, which described our expectations for the safety and the efficacy of these vaccines. That's the standard that we would use before we could issue an emergency use authorization. We then, for the initial emergency use authorization required manufacturing data that was equal to what we would have, or nearly equal to what we would have required for a biologics license application, and we required effectiveness data that was near or equal to what we would have required for a biologics license application. We couldn't speed up time, so in order to get the vaccines to people in need when thousands of people were dying, we actually allowed the safety to be authorized with just 2 months of median follow-up rather than the normal 6 to 12, but we were confident that that would capture adverse events. So we had good safety data. And then when we went to finally do the biologics license application, we go through very large data sets.
Let's talk about the VAERS for a second. So that is a system where individuals can report their symptoms that they believe may be associated with the vaccine. How do you then determine if it in fact is associated with the vaccine or it's not associated with the vaccine?
Yeah, so if VAERS it's essentially a front door where anybody
It's a screening mechanism.
Correct.
Yeah.
People can put in anything that they think may be associated with that vaccine. That means that we have a lot of reports that may not exactly be associated with the vaccine, but there's a process for reviewing those. Every serious adverse event in VAERS is followed up. Medical records are collected, and autopsy records are collected to identify that. We don't use VAERS to determine if an adverse event is caused by the vaccine. We don't use it to look at trends about whether the vaccine is more commonly causing a problem versus what's in the general population. We use different data sets to do that.
This rigorous surveillance system has demonstrated its effectiveness for the COVID-19 vaccines, detecting exceedingly rare cases of thrombosis with thrombocytopenia syndrome, or TTS, among patients who received the J&J vaccine, for example. Dr. Jernigan, could you explain how the detection of these cases reflects the effectiveness of CDC's vaccine safety surveillance system?
Yeah, I think these indicate that the process works. You mentioned the TTS associated with the J&J vaccine. The systems have been able to pick up myocarditis and show that the risk of getting myocarditis is much lower among those vaccinated than among those that were unvaccinated. It's even a system that we've been able to pick up signals that turn out not to be signals. So a thing called ischemic stroke can occur, and we picked up a signal, but when we continued to follow it, it went away. So we get signals that sometimes are there, sometimes aren't, but it allows us to see things early so that we can act quickly and change recommendations when needed.
According to them, after they declined, you and former FDA Commissioner Janet Woodcock relieved them from the roles in the approval process. They said that they felt, quote, substantial pressure, unquote, from you to approve this vaccine faster than they thought was defensible. My question is, did anyone instruct you to speed up the approval timeline faster than September 15th, 2021?
Chair Comer, thank you for that question. I think it deserves an explanation, but what was going on during that summer that changed the situation was in the week ending July 10th of 2021, there were 1,645 deaths. In the week ending August 14th, there were 9,406 deaths. There were an increasing number of deaths from COVID-19, and there was clear knowledge that having an approved vaccine would help Americans feel more comfortable getting vaccinated. So we felt speeding up the vaccine approval process.
So let me interrupt. Did anyone instruct you, or is this just a decision you made on your own?
This was a decision that I had made on my own.
So why were you pressuring the doctors and then removing them from the approval process when they disagreed?
The approval process was one that was needed to move as rapidly as possible. One of the physicians...
Okay, let me we may go back to that. Do you recall any conversations regarding the need to approve the vaccines in order for it to then be mandated?
There was an acknowledgement that an approval could allow vaccine mandates to occur, but they were not conversations over that it were...
So Dr. Gruber wrote that you and Dr. Woodcock expressed your opinion that absent a license, states cannot require mandatory vaccination. Do you recall this conversation?
I don't know what you're referring to, but there's probably it's just a statement of fact that once you have a licensed vaccine, a mandate could be placed.
Do you recall why Dr. Gruber and Dr. Krause expressed concern about accelerating the approval of the vaccine?
They were concerned about the workload.
Okay. Dr. Gruber wrote that taking a thorough approach was important because of increasing evidence of association of this vaccine and development of myocarditis, especially in young men. Do you recall seeing safety signals regarding myocarditis in young men during this time?
There were safety signals known, and they were placed on the label. But Chair Comer,
let me finish. Did you ever have any conversations regarding the vaccine approval with the Department of Defense?
I can't recall any conversation directly with the Department of Defense.
Did anyone else at FDA have conversations regarding the vaccine approval with Department of Defense?
I can't speak to the conversation of others I'm just not aware of.
Did you express your desire to approve the vaccine by August 20th?
I did.
And it was ultimately approved on August 23rd, correct?
Correct.
And just for the record, the military mandate was issued on the 24th. And that is interesting timing.
So as we mentioned, there are a number of different surveillance systems that we monitor. Once we see any signal there, we communicate that to the general public, to healthcare providers, provide that information to the advisory committee, and then recommendations can be changed. So we are committed to transparency. We provided information on risk-benefit analysis at 30 different ACIP advisory committee meetings over the last 3 years. So we get that information out so people can understand.
But I do want to point specifically to the concerns about post-vaccination heart issues, particularly myocarditis in young people. In fact, myocarditis is one of the injuries that have been compensated for. And I'd like to know from both either Dr. Jernigan or Dr. Marks what specific monitoring or I guess safety monitoring or research projects are currently underway by the CDC or the FDA to delve deeper into this issue.
So I'm happy to start. Thank you for that question. We have had multiple go-rounds in our adverse event reporting systems that use active surveillance. One of them is called the BEST system to look among large databases, claims databases, and electronic healthcare records to look at the incidence of myocarditis in vaccinated individuals versus non-vaccinated individuals. And some of that work has now been published. I think it leads us to understand that after the first COVID-19 vaccines, where the primary series was given 2 doses 3 or 4 weeks apart, there was a risk in the younger age range of males that was about 1 in 10 to 1 in 20,000, 1 in 10,000 to 1 in 20,000 individuals got myocarditis. Now with the spacing out of the vaccines, that risk is almost undetectable.
Dr. Marks, my colleagues have attempted to distort an email that you sent in July 2021 regarding the authorization of the Pfizer booster. They've claimed that this is evidence of political interference that undermined patient safety in favor of expediting the timeline for this product. Dr. Marks, I'd like to give you an opportunity to correct the record on the misrepresentations of this email that have been made, and just give you, I have 1 minute and 15 seconds. It's all yours.
All right. Thank you so much for the opportunity, Congressman Ross. At the time that these boosters were authorized, just before, we had an increasing number of deaths starting to run into the 1,000 per day in the United States. And there was great urgency to think about what we could do to try to reduce that number of deaths. It had become clear that immunity was waning, and that potentially giving a booster could restore immunity and decrease the number of deaths. And So we moved with all due haste, not because of any kind of external pressure, but because of internal pressure. We felt compelled to try to save American lives because thousands of people were dying. And as somebody who was one of the architects of Operation Warp Speed, I had a pretty good idea about how to find efficiencies to move forward. It was critical to move as fast as we could. And by the way, the data that has now been published showed that introduction of that first booster was probably responsible for saving hundreds of thousands of lives as we entered the Delta and Omicron waves. Thank you.
If I heard you right, just recently you said, well, we don't want to give out too much information because of privacy rights. But certainly we could put out how many were confirmed deaths, couldn't we?
Congresswoman, thank you so much for that question. I fully agree with you that we probably have not done a good enough job of communicating sometimes the actual numbers of deaths versus what's in VAERS. In fact, we just nearly fell prey to it here at this hearing. There are only handfuls, and I'll ask Dr. Jernigan to comment on this as well, handfuls that we can actually associate with the actual
Can I ask
vaccine.
why you haven't done it? I mean, this was August of 2021. It seems very logical to me that if you're saying people, the public shouldn't count on VAERS because anybody can report to that, which they can, why wouldn't you as actively report to the public, well, we confirmed this really low number of cases that actually were caused by vaccines? I mean, it's been years now. Why haven't you done it?
We did present that in various settings, including at, I believe, at the Advisory Committee of Immunization Practices. It was mentioned at our vaccine advisory committee. It perhaps did not go as broadly.
Is there an easy place for the public to find this? I remember you gave us some kind of link back in 2021, but it was really difficult to get to, if I remember right. And so why not spend the time like making, if the goal is to give confidence to people in getting vaccines, why in the world would you just not say, okay, what we have done is we've investigated these deaths, we've done this, we've done that, and we've only found, you know, a handful. I mean, it doesn't make any sense to me.
How many lives have been saved by the COVID-19 vaccine generally?
It's estimated about, in the United States, about 3.2 million lives, and it's estimated that globally COVID-19 vaccines have saved over 14 million lives, conservatively.
I'm not a doctor, but I have a PhD in recognizing bullshit when I hear it. I'd like to point out to everyone that we knew early on, as a matter of fact, everyone knew early on, that the people that were at risk of hospitalization and dying of COVID were those that were obese, had diabetes, were over the age of 65. We also knew that children were at no risk, practically zero risk of being hospitalized or deaths from COVID-19. We knew that young people, healthy young people, were not at risk. However, Dr. Marks, you rushed through this process of authorizing these vaccines, even though you knew the side effects, you knew about myocarditis, and you knew about the studies. So let's be very real about the situation that we have. Here we have, let's talk about the reports on VAERS. Some people in here are trying to belittle these reports, but these reports come from people that died, people that got injured. And in December, in the middle of December, I think it was the 10th or the 11th, the first vaccine was approved. It was authorized under emergency use. Boom, 10,596 reports in less than a month. 2021, 706,767 reports on VAERS for vaccine injuries and deaths. 2022, it was 206,676. 2023, and it went going down because the mandates stopped. Now, let's talk a little bit more about the vaccines. Here we have reports. Deaths, 18,372. Permanent disability, 17,842. Hospitalizations, 86,452. Emergency room or office visits, 315,048. Serious adverse events, 113,449. This is from the Congressional Research Service about VAERS. all kinds of injuries, miscarriages, heart attacks, myocarditis, permanent disability, neurological problems, and it goes on and on and on. These are the reports from people being forced to take vaccines. Shouldn't have happened. Mr. Grimes, I've just told you the numbers of reports. However, under CICP, there are only 10,640 of these COVID-19 claims are currently pending or are in review. And as of January 1st, 2024, CICP only compensated 11 of the 40. Oh, wait, let's make that number clear to everyone. Only 11 people have been compensated. Only 11 people have been compensated. Out of the 40 COVID-19 claims it determined were eligible, only 40 were determined eligible. That is amazing. And the average award was only about $3,700. On the other hand, the average VICP payout over the last 35 years is approximately $490,000. If you die or get injured from a COVID-19 vaccine, your average payout's $3,700. I'd like to recognize someone in the room today is here, Brianne Dressen. She's met with you, Dr. Marks. She's met privately with you about her vaccine injuries. She participated in a clinical trial. She was injured, and then she was dropped from the trial for the COVID-19 vaccines. Her medical expenses are $433,000 a year. She filed with CICP. Mr. Grimes, she's gotten no response. She's right here. Could you raise your hand, Ms. Dressen, please? Thank you. Perhaps you could meet with her after this meeting. Dr. Marks, you admitted to her that vaccine injuries are real. That they're real. Although you rushed through the authorization, and now you've authorized that children should receive these vaccines, and even babies as young as 6 months old. That is shameful. That's shameful. I'm not asking you a question. I'm going to continue speaking. Thank you. This is my time. The National Institute of Health also saw Ms. Dressen for her neurological complications that have been quite severe. They studied her, and then they dropped the study and asked her to be quiet about it. These are the real stories of the vaccine injured. They were totally, completely wiped off of social media. There's been thousands of peer-reviewed medical studies, thousands of them studying vaccine injuries. They are real. People are dying. People are having heart attacks, strokes, blood clots, and many other countries are dropping the COVID-19 vaccine and saying we shouldn't give them to children. It's time to be honest about the vaccine injured, and we need to stop allowing these COVID-19 vaccines to be given out to children.
Gentlelady's time has expired.
The COVID vaccines cause turbocancers.
I'm a hematologist oncologist that's board certified. I don't know what a turbocancer is. It was a term that was used first in a paper in mouse experiments describing an inflammatory response. We have not detected any increase in cancers with the COVID-19 vaccines.
Thank you, and I thank you for correcting the record.
May I just add something here? I do need to apologize to the 1,000 or so parents of children who are under 4 years of age who have died of COVID-19 who were unvaccinated because there were deaths and are continuing to be deaths in children, and that is the reason why they need to get vaccinated. Thank you.
Mr. Chair, I would also, on a point of personal privilege, remind members of this committee, even though I am not the chair, that there should be some sense of decorum, and vulgarity should be discouraged. So if I ever say that I'm a PhD in BS, it means Bulgarian sunshine. You will not hear me talk about explicitly the thing that I won't mention here today. There are people watching across this nation who want, and quite frankly, really expect that the Congress, if no other place, will conduct itself in a way that does not insult any of them personally because of vulgarities, and in a way that we should, in fact, conduct business.
Can you please speak to how the agency is taking steps to ensure vaccine manufacturers have the essential time needed to adapt their products accordingly and scale up production for vaccines for new virus variants?
Congress Miller Meeks, thanks very much for that question. I would certainly agree with you that at FDA we take seriously the need to have choice among vaccines, because that will allow a greater vaccination rate, because we understand that some people may not feel comfortable with certain types of vaccines. They may want a more traditional vaccine rather than a newer vaccine. That's why we've been continuing to work with manufacturers to try to make sure that when we roll out the next update, we will have a diversity of choice, at least more than one type of vaccine that will be available.
Dr. Grimes, what's the rate of denial for compensation for claims for COVID-19 vaccines in CICP?
So thank you. I don't have the rate, but we have adjudicated 2,214 claims today.
I think it's about 98%. And if I can just quickly follow up, I understand that there's a current backlog of claims in CICP by about more than 10,000. Why is there a backlog of claims for the COVID-19 vaccines?
Thank you for that question. So at the beginning of the COVID-19 pandemic, we had not had a direct appropriation with the CICP. We also had only 4 staff. When we received our first direct appropriation in fiscal year 2022, we were able to ramp up quickly, and now we have over 35 staff who are assisting to adjudicate claims.
Dr. Marks, can you please explain how the FDA evaluates vaccines to ensure that they are safe and effective for age groups that they are intended to be used for?
Thanks, Congresswoman, for that question. So every vaccine that we authorize or approve, we require to have manufacturing information to show that it's high quality, and that we have to have information on its effectiveness and safety in the specific age population that it's being prescribed in, or we have to be able to understand that it's going to function similarly in that age group that we're authorizing or approving it for.
Early on in the pandemic, the federal government provided billions of dollars to pharmaceutical companies for development. Much of that work was aided by the work of taxpayer-funded scientists at NIH. Then we purchased the vaccines back and from the pharmaceutical companies. Next, the FDA and the CDC, which were responsible for evaluating the safety and effectiveness of the vaccines, cleared them for emergency use. Then, not content with recommending the vaccines and providing information for the American people to make their own decisions, the federal government attempted to force nearly everyone to get the vaccine, blatantly disregarding scientific evidence and constitutional considerations. At the same time, the government provided the vaccine manufacturers with special liability protections, ensuring they can't be sued for any adverse effects. And instead, a government bureaucrat gets to decide whether or not someone was injured and offer them a minuscule amount of money as compensation if they manage to make it through an arbitrary process, which is very intensive. Does the COVID-19 vaccine prevent the disease from getting it, from you receiving the disease? Does it?
You can't have a yes or no answer to that question, because it will reduce your risk of serious outcomes such as death.
Right. I'm not debating whether or not it helps people. It mitigates some of the, but what the people heard.
So I care if I'm alive or dead, so I think they do a very good job of preventing death and hospitalization. They may not prevent
I agree.
Infection.
The mantra at the time was to stop the spread, and so we were understood that we either did not receive it or could not transmit it when it was released. Could you speak to that, Dr. Jernigan? Can you receive it or can you transmit it after receiving the COVID-19 vaccines?
Yeah, I think having worked at CDC for 30 years and seen the benefits of vaccine, we have to make the best recommendation.
Can you transmit it or can you receive it after receiving the COVID-19 vaccine?
We need to make the best recommendations that we have.
That's a yes or no question. It's very simple. Commander Grimes, can you receive?
I think we make the best recommendations for the public as we
Can you still get COVID after getting the COVID-19 vaccine?
Yes.
Yes.
Yes, okay.
That's correct.
Does it prevent you from transmitting it?
Although it may, there's data that shows that earlier in the pandemic there was some reduction in transmission. The data on that are very challenging to pin down, but it does not absolutely prevent transmission. So
it does not prevent transmission. Thank you very much.
Do you feel it is more appropriate to have petitioners, your word, for COVID-19 claims to be paid by the vaccine manufacturer or by the American taxpayer?
So the petitioners are for the National Vaccine Injury Compensation Program, and those are through the routine administration with an excise tax levied on it, whereas the requesters through the CICP are paid for compensation of claims through appropriated funds, and through administration of the program is also paid from those appropriated funds.
Am I accurate in saying it was 13,000 claims approximately?
We have approximately 13,000 COVID-19 countermeasure claims, about 9,600 of which allege vaccine.
Okay. And of those, which ones how many have been closed?
2,200 about.
Yeah, okay. And then the number is 35 employees now that are handling those claims, right?
Yes, so since we...
it's okay, I got to be quick because we're on the timeline here.
Understood.
How many claims are we processing per month now?
So in the year 2023, we processed 90 claims per month over that year, and that velocity increased throughout the year.
And of those 2,200 claims, how many have been shown to have some merit for injury?
Currently, there are about 40 that have been found to have a injury that was directly caused by a covered countermeasure.
Okay, so pretty small percentage, correct?
Yes, sir.
Okay, so just to do the math, that means that each employee is handling about 2.7 cases per month and showing 40 out of 2,200 cases that have been processed so far. Of the 13,000, that means we probably have about 10,800 cases in backlog. I know you've asked for more employees so you can process faster, but at 2.7 per employee, it would take us about 10 years to process the remaining claims.
Now, if you lower the risk of getting the illness and getting sick, or if you increase your immune response enough to prevent symptomatic infection, then wouldn't you say that that reduces the risk of spreading it to other people? Dr. Jernigan?
Yeah, I think the more you can lower the viral load, the more likely you're going to be able to.
The viral load is a medical term that's important to understand. So when you look with the vaccines, increase your immune response, combats the virus, lowers the viral load. If you have a small viral load, you decrease the risk of spreading the disease. Is that correct, Dr. Marks? Do I have that physiology or pathophysiology ready? Right?
That would be correct.
That'll be correct. So would it be correct to say that indeed vaccines reduce the spread and for some individuals prevent the spread of the virus to other people, correct?
So I think we can say that that's a general statement. I wouldn't want to make it as an absolute statement.
Correct. That's my point.
In the spirit of today's hearing.
That's my point. Is by intentionally using absolute statements like that without the nuances, and people should know better. They're disinforming the community. And what I said was not absolute. I said it reduces the risk of spread. And for some people, it reduces the spread. So it does, and it can reduce the spread with that nuance.
If there's no further business, without objection, the Select Subcommittee stands adjourned. Thank you all for attending.